Now I'll be talking to you regarding hairy cell leukemia and CLL. Interferon alpha is used for which? Answer is hairy cell leukemia. Let's learn more about this particular thing. Interferons are the cytokines and they are released in the body in response to viral infection and neoplasia. They are classified according to cell of origin. Okay. So the type of receptor and of course the type of receptor they bind. So from where they are arising and which receptor they are binding. This is how we label them. Those who bound to alpha, beta, they okay. While gamma receptor they bound. So interferon gamma bound to type 2 receptor. But TNF alpha and TNF beta they bind to type 1 receptor. It means type of receptors. Type of receptor 1 and 2. Alpha and beta they bound to 1 and the gamma bounds to type 2. Now I have a question for you. Write down the answer. I give you 30 seconds. I talked to you regarding interferon beta. Write down the answer. Tell me in which condition we use interferon beta for the treatment. In which disease we use interferon beta for the treatment. You get 30 seconds to think and write the answer. Well, the answer is multiple sclerosis. Okay. Now we talk about interferon alpha. It is produced by the leukocyte and it has an antiviral action. Point to be noted. The cell of origin is leukocyte and we know they bound to type 1 receptors. But pharmacological they have an antiviral action. So now interferon, this alpha, they are used in following condition: hepatitis B and C, Kaposi's sarcoma, metastatic renal cell carcinoma, and the hairy cell leukemia. So these are the few conditions where we use. So keywords are leukocyte, hepatitis B and C, Kaposi's, metastatic renal cell carcinoma, and hairy cell leukemia are the uses of interferon alpha. So with this background of basic concept about interferon, let's read or talk more about hairy cell leukemia. It's not a very common, it's a rare malignancy, much less common as compared to multiple myeloma. It's a disorder of the B cells, okay. Much more in males, 4:1, and the age is again above 50 years. That means it's a disease of the elderly person. Okay, so let's see what are the clinical feature or the important. They have a pancytopenia. Point to be noted. This is a very important point. It is a leukemia, but patient has pancytopenia. And they have a splenomegaly. How much? They have a massive splenomegaly. Massive splenomegaly means spleen is so enlarged, it comes up to the umbilicus. Okay, massive splenomegaly is there. And they are vasculitis in 1/3 of the patient and they manifest as erythema nodosum. Of course, in fact, it's again a very important feature. In fact, these three things, they consider as a triad of triad of hairy cell leukemia, pancytopenia, massive splenomegaly, and vasculitis-like feature like erythema nodosum. Now, if you do the bone marrow aspiration, you get a dry tap. Despite hypercellularity, this is a unique thing. It's really a very unique thing. One condition where we have a dry tap with a hypercellular marrow is there. Why? Dry tap means you are doing bone marrow aspiration. But when you see, you don't get anything. You're not getting any finding. So we call it dry tap. Reason. But surprisingly, the bone marrow is hypercellular. Let's learn why this happened. Basic concept. Here is the bone marrow. Okay, here are the cells. Cells. Hypercellular. But in this, lot of septa are made by the fibrous tissue. So when you try to put a needle, you may enter in a place where there is no marrow. So that means we are getting hypercellular in a localized pocket-wise, right? So despite having hypercellular marrow, because of fibrous tissue, we are getting dry tap. So unique thing is dry tap despite having hypercellular marrow. And the classical thing, they have a tartrate resistant acid phosphatase cells in the bone marrow. Okay, this if you are getting this trap strain, virtually diagnostic that you are dealing with hairy cell leukemia. Treatment, the first line treatment is cladribine. Again, a point to be noted. He can ask the question, first line treatment is cladribine. But we do use interferon alpha, we also use rituximab. In fact, the cladribine has been introduced only last few years. Before that, it was only interferon alpha, which was being used for treatment of hairy cell leukemia. But as per NICE guidelines latest, previously it used to be interferon alpha. Now the NICE guidelines say the first line treatment is cladribine, or even pentostatin can be given. The second line treatment is rituximab or interferon alpha. Question 2. 72-year-old woman diagnosed with chronic lymphocytic leukemia. And now, what is the next investigation? Immunophenotypic is the answer of this question. Why this the answer? Why not others? Let's learn more about it. So in CLL, immunophenotyping is the investigation of choice, which is going to help us in making better diagnosis. So what you will be getting, if you do, we will be getting CD19 positive. So when we are doing immunophenotyping, we want to know what type of CD cells are there, 19. But of course, this is a B cell marker. But very interestingly, they also have CD5 and CD23. They are also seen in CLL. So this is a unique finding that we are getting CD19 plus CD5 plus CD23. Something, a unique finding. So that's why it's very essential to do the immunotyping in a patient of CLL. Okay. What are the clinical features of a case CLL? Often none. Often none means they are totally asymptomatic. Totally no feature, and the age group is 60 to 80 years. That means you can say it's very, very senior people. It's the commonest leukemia at this age group. Okay. So no symptom, and so they are incidentally picked up due to lymphocytosis. Incidentally, patient has come for maybe health checkup and you have done the complete blood check, you find the lymphocyte count is very, very high. Okay, then it is alarming. In addition to that, there may be anorexia and weight loss may be there. Bleeding infections can occur, and lymphadenopathy is a features. Okay, and remember, lymph nodes are usually not seen in chronic myeloid leukemia. Right? So here we have spleen is enlarged in CLL. But in CML, spleen is enlarged, but it is massive splenomegaly. Massive splenomegaly means that it has come onto the umbilicus, and this has occurred in hairy cell leukemia also. Investigation, full blood count, FBC, at time they write. In UK, they have a trend of writing FBC. In other part of the world, it is CBC. Both are same. CBC is complete blood count or full blood count, matter remains same. There is usually absolute lymphocytosis. Only lymphocyte. They are, and what? They are small cell B lymphocyte. Anemia is a feature, and blood film smudge cell. This is the classical. If you get smudge cell, is a golden line to remember that you are dealing with CL. There is no other option. So friends, the smudge cell is equal to CLL. Golden line to remember. So single word is getting clue. I always say, well, if I say Eiffel Tower, Paris, Taj Mahal, Agra, so they are the symbolic. If you get smudge cell is CLL. For Eiffel Tower, there cannot be any other option. Okay, it is Paris only. So here also, right? So you are getting this look. All this they're all lymphocytes, and this is the smudge cell. Smudge cell. Now you will definitely like to know what the smudge cell is. Look, like this a smear has been made, and so we have a smear, and they make a smear. Let's presume that this is the smear. Okay. And traditionally we keep a cover slip. We keep a cover slip before you watch under the microscope. Now in these, the cells are so fragile, they break. The cells, they break, and you get picture like this. And this is so-called smudge cell. So as I said, smudge cell means you are dealing with CLL. Okay. Question 3, CLL. Mostly due to what? Monoclonal proliferation of B cell lymphocyte, right? Of the B lymphocyte, let's look into other option. Is the polyclonal proliferation? No way, out. Large granular lymphocyte? No, they are small lymphocyte. T lymphocyte? No, they are B lymphocyte. Polyclonal T, no B. So easily we could rule out, if you remember, only one line, which I told you, there is a small B lymphocyte proliferation occurs. Okay, called by monoclonal proliferation of the B, small B lymphocyte. Small B lymphocytes. Question 4. We are getting a 74-year-old woman, chronic lymphocytic leukemia with lethargy. HB is 7.9. Platelet 1.58. WBC is 24,000. Normocytic normochromic anemia. So what the most complication she will like to have? She like to have is warm autoimmune hemolytic anemia. And look into this, she has 7.9. Why this the answer? Why not others? Let us discuss more detail and then we'll come to know why anemia is occurring in these patients. So let's learn more basic concept about CLL, basic concept. Let's see how we do the staging. Stage 0, 1, 2, 3 and 4. In stage 0 of CLL, there is increased TLC count. Stage 1, lymph nodes are enlarged. LN stands for lymph node are enlarged. Stage 2, spleen get enlarged. These three occur due to disease process as such. But in due course of time, these patients develop antibodies, warm autoantibodies against the RBCs and the platelet. So if they have antibodies against the RBC, they will develop Coombs positive hemolytic anemia. And later on, they are going to develop antibody against the platelet, so they are going to have thrombocytopenia. Thrombocytopenia, platelet count is reduced. So now these two, that means anemia and the platelet count is reduced, thrombocytopenia, but they are due to autoantibodies. These two are the strong indication of using corticosteroids. So up to the stage of this disease, we can use the drug like fludarabine, we can use chlorambucil, but the patient has anemia or thrombocytopenia, then it's a definite indication of using corticosteroid. The question can be asked to you this way also: which of the following is the most advanced stage of disease? Increased TLC count, lymph nodes, spleen, anemia and thrombocytopenia. Your answer should be thrombocytopenia. So now let's go back to the question again. So what we are getting in this patient, we are getting a case of CLL, they are coming with lethargy, anemia is there. But as far as platelet count is still in the normal range, so that means the patient has warm autoantibodies and due to what he has developed autoimmune hemolytic anemia. So this patient should also be given corticosteroid. So warm autoantibodies, the answer. It doesn't lead to cold autoantibodies, no. It's not a case of in PNH. In PNH, there is first morning urine sample. First morning urine sample is black, the whole day urine is clear, is PNH. Microangiopathic hemolytic anemia we see in condition like HUS, not in CLL. Sideroblastic anemia is not a feature. So definitely the answer is warm autoantibodies. Okay. Question number 5. We have a patient of CLL. The fourth admission for pneumonia. Most likely reason for this is hypogammaglobulinemia. In this, again, a very important feature of CLL is immunonormal, good immunoglobulin level is reduced. Why? The cells, they are all going into cancer. They are not going to make the normal cells. So every cell is getting converted into a cancer cell, and that's why the B cells, which are making cancer cell, they are not making the plasma cell. The plasma cell are made less, and that lead to reduced immunoglobulin level. Reduced immunoglobulin level will make the patient prone to infection, particularly pneumonia like in this case. patient has been sick for the fourth time in 6 months, has been hospitalized for pneumonia because of what? CLL. Hypersplenism is usually not seen because here the spleen is not that big and large. Decreased lymphocytic survival, no, it is the cancer cell which are getting made and they are not making the immunoglobulin. Transformation to high grade lymphoma is a very uncommon. This doesn't contribute to reduce the immunoglobulin level. And immature lymphocyte, no, they are not immature, they are cancerous B lymphocyte and they are not making. So by rule out technique also, we are getting hypogammaglobulinemia, which is the most common cause of infection in these patients, recurrent infection. Thank you very much. God bless all of you.